I'm Fabien Zelim from the Lyon Hepatology Institute, and I would like to thank the EASL Governing Board for giving me this opportunity to do the wrap-up session on viral hepatitis. So I had to make a very difficult job because I had to select abstract from an abstract book from 860 pages. So this presentation is really based on my personal opinion. And I would like to also thank the investigators who provided me their slides to be shared today. So I've decided to focus my presentation on the important viruses that lead to liver disease, hepatitis E virus, hepatitis C, hepatitis B, and hepatitis Delta, with a main focus on how to cure the infection. So first of all, regarding hepatitis E, there was a very nice presentation from Dr. Klein and colleagues, which look at the targeting of cellular cathepsins to inhibit hepatitis E virus infection. So they showed a pivotal role of cathepsin in viral entry. They showed that cathepsin L cleaves viral particle, a process that is inhibited by the addition of the compound K11777. And this cathepsin inhibitor was shown to reduce hepatitis E virus infection in hepatoma cells, but most importantly in primary human hepatocytes. So this very important paper opened really a new perspective in terms of translational research for hepatitis E. Regarding hepatitis C, I have selected three abstracts. The first one is from Dr. Ogawa from Japan, who presented the results of a large cohort of 3,000 chronic hepatitis C patients who achieved SVR by DAA. And he showed that HCV cure was associated with a decreased liver morbidity and mortality after HCV elimination by direct-acting antivirals. But very interestingly, in that cohort, they look at the subgroup of non-cirrhotic patients who were shown to develop liver cancer, especially in the age group over the age of 60. So this is providing clinical information that non-cirrhotic patients age over 60 should be monitored over a long period. The French study from Dr. Naon with two different cohorts comprising more than 8,000 patients who achieved SVR. Among them, almost 300 patients developed HCC. And what they showed here in that study, that HCC may develop following HCV cure despite fibrosis regression. And this highlights the need for new predictors of HCC in patients who had cured HCV infection. And the next abstract goes in that direction with the work, elegant work done by Mukherjee et al., which showed that chronic hepatitis C virus infection actually deregulate the human liver circadian transcriptome and epigenome through the deregulation of the deacetylase SIRT1 in both a preclinical model, the human liver chimeric mouse model, but also in patients' liver tissue samples. So these results, very interesting results, support the fact that virus-induced perturbation of the liver clock may be involved in liver cancer development and may help to discover novel biomarkers to predict HCC. Now let's switch to hepatitis B virus, and the slides that are selected are mainly dedicated to the HCV cure strategies. And mainly on novel approaches to target the viral replication cycle and the viral mini-chromosome, and strategies to restore the antiviral immune responses. A first very elegant study was done by Dr. Harrison et al., which used a new gene editing platform, the Arcus nuclease, to target both cccDNA and integrated sequences, and they did in that study a preclinical assessment of the safety of the product, and showed with extensive genome-wide screening that there was no detectable off-target gene editing with that approach in PHH, and that there was no additional translocation versus the control condition, and the non-human primate data were supporting the advancement of this product in the clinics. Another very innovative approach is to target the viral genome with novel epigenetic technologies, and Dr. Anglero Rodriguez showed that we can target both cccDNA and viral integrated sequences by methylating the viral DNA. They showed that it is highly specific with no off-target changes, and with a durable effect on the viral markers and HBS expression in the two mouse models that he used, the AAV HBV and the transgenic HBV mouse models. So now we are waiting for a translation of this technology platform to the clinical studies. Another very important investigation was presented by Dr. Kozinska and colleague, where they studied in highly viremic mouse transduced with AAV HBV, a combination of siRNA against HBV and PDL1, together with a novel therapeutic vaccine, the TherVac-B, and they showed that the triple combination was necessary to induce in these high titer HBV carrier mice a profound suppression of HBs antigen and elimination of HBV positive hepatocytes, and we see that in the clinical studies with other compounds that this approach, this concept may be highly relevant in patients. Another presentation was done by Dr. Roca Suarez and colleagues who showed that precision cut liver slices, PCLS, is a very interesting preclinical model as it preserves the liver lobule architecture and the liver microenvironment, and they showed that the PCLS are permissive to HBV and HDV infection ex vivo, and that this model is particularly relevant to investigate host-targeting agents such as Bulevirtide and selgantolimod as a proof of concept. So this model may be interesting in the future to assess novel therapeutic approaches. Regarding clinical studies, you know that the drug pipeline for HBV is extremely dynamic, with drugs inhibiting viral replication, inducing antigen reduction, and strategies to stimulate the immune responses. So I will show you a few examples of what were the highlight of this meeting. First, a study that I selected is a capsid assembly modulator ALG 184 with or without entecavir, which showed in an extended treatment in E-positive patients, profound reduction of HBV DNA and HBe antigen, which really shows that this class of drug is still alive in the strategy for drug development. There was a very interesting study of a long-term follow-up of patients who had received in clinical trials the siRNA ARC520 or the J&J 3989 with a 4 to 6 year follow-up. And the study presented by Dr. Mack showed a maintenance of the HBs suppression over time with a mean reduction of 0.8 log, and they could observe 20 to 37% of patients with HBs below 100, but only one patient had an HBs zero clearance. The question is, what should we combine in addition to siRNA? So the phase 2 Octopus study presented by Dr. Asela was investigating the combination of the siRNA J&J 3989 with a low dose of anti-PD-1 nivolumab in E-negative, virologically suppressed chronic Hep B patients. And you see here the trial design and the results showing that the addition of nivolumab at low dose did not improve the HBS response of J&J 3989. Of note, there were 2 treatment-emergent TSH suppression that led to the amendment of the protocol to stop nivolumab in the protocol. Another very interesting study of combination with siRNA is zalnesiran with or without an immune modulator, either a TLR7 agonist, risotolimod, or pegylated interferon, a phase 2 randomized controlled study in the Piranga open-label platform presented by Dr. Wu and colleagues. This study showed that HBS loss could be obtained with even after 48 weeks of follow-up in patients with zalnesiran alone or a combination with risotolimod or with pegylated interferon, but the rate of HBS seroconversion was highest in patients who received zalnesiran combined with pegylated interferon. So here we start to see potential for functional cure. Another very interesting study was the combination of imdusiran administered with a therapeutic vaccine, VTP-300, in nuke-suppressed patients. And in that study, what was very important is that the combination of imdusiran with the therapeutic vaccine led to maintenance of lower HBS antigen during the post-treatment follow-up period versus the placebo. And the nuke discontinuation was achieved in the majority of patients, with more patients meeting discontinuation criteria in the group receiving the vaccine, the therapeutic vaccine. Now, in addition to the siRNA combinations with other drugs, there's the antisense oligonucleotide. We know that bepirovirsen is now has entered phase 3 clinical trials, and there was a very interesting study, exciting study with a new ASO, AHB137, presented by Dr. Gain, the results of a 4-week treatment, and after 4 weeks, 50% of patients showed more than log reduction of HBS and 30% more than 2 log reduction, and 5 of 40 patients achieve HBS loss within this short duration. And now we are eager to see the longer term follow-up. But overall, what we start to see is repeatedly in clinical trials that we can achieve HBS loss, at least in some patients. Regarding hepatitis Delta, we'll focus my presentation on strategies to treat hepatitis Delta and potentially cure it with either entry inhibitor or neutralizing antibodies or siRNA. First of all, a very novel approach, a novel orally bioavailable small molecule inhibiting viral entry, ABI 6250, and it was shown to be highly potent, NTCP selective as an entry inhibitor, and the PK profile in the preclinical model supports a low once daily dosing in patients with chronic hepatitis Delta, and we are expected to see the phase 1 trial by the end of the year. There was also an important study. We're using an HBS monoclonal antibody, BGT-778, presented by Dr. Agarwal, a phase 2 study showing that 24 weeks administration resulted in virologic response in 90% of the patients and HDV RNA below 10 IU in 50% of the patients. So this is providing promising results to treat chronic hepatitis Delta. The other very important study was a combination of monoclonal antibody tobevibart in combination with elebsiran, siRNA against HBV. The phase 2 Solstice study presented by Dr. Asela, which showed that the de novo combination of the two drugs exhibited high rates of virologic suppression in 11 out of 11 patients with HDV RNA undetectability and more than 50% ALT normalization at week 24. We had an update of the compassionate use program of the nucleic acid polymer REP2139 in hepatitis D with advanced liver disease, advanced cirrhosis, who failed previous treatment with pegylated interferon and or Bulevirtide. And it was shown that the REP administration with or without interferon could lead to 60%, approximately 60% HDV RNA undetectability in these patients, and HBS loss in 25% of these patients. So this is providing some very nice data to rescue patients who are failing the different lines of therapy. Now, trying to finish the presentation on Bulevirtide, I've selected this important study of Bulevirtide monotherapy in cirrhotic patients. And in that case control study presented by Dr. De Gasperi, it was shown that Bulevirtide in the cirrhotic patients could decrease the risk of liver-related event and liver decompensation, but had no significant effect on the HCC development. So it is here to emphasize the fact that these patients need to be monitored for HCC development. A very important study was presented by Dr. Asela on the phase 2 MIA-204 study combining Bulevirtide with pegylated interferon. And in this trial design, it was shown that Bulevirtide 10 milligram plus pegylated interferon followed by Bulevirtide 10 milligram for an additional 48 weeks showed higher rates of undetectable HDV RNA versus Bulevirtide 10 milligram monotherapy at week 24 and week 48 after the end of treatment, which provide clues for finite duration treatment and potential cure for hepatitis delta. And these data were confirmed and supported by an analysis by Dr. Alvais of the HDV RNA in the liver biopsies of 42 of these patients in this trial, and showed that the biological response in the liver was most significant in those who received the combination of Bulevirtide 10 milligram plus pegylated interferon. And with this, I would like to give you the take-home messages for my highlights of this meeting. Very interesting and dynamic meetings with new data regarding hepatitis E. I think we should continue our translational research effort to find new drug targets. For hepatitis C, there's really a need to identify predictors of HCC after HCV cure, and we have seen for HBV that functional cure is in the horizon, and that for hepatitis delta that there's a potential for finite treatment to cure the infection. And with this, I would like to thank you for your attention.